Hey, this is Christopher Reeder. I'm back with another antibody lecture here. We're going to address how to figure out the specificity of an antibody. This is honestly the most fun aspect of this field because you're pretty much getting paid to solve puzzles, which can save people's lives. Yeah, it feels pretty good. So after this lecture, you should be able to explain the rule-out method of antibody identification. This is the most common technique for narrowing down the specificity of a potential antibody. You'll also be able to describe the concept of dosage as it relates to homozygosity and, more importantly, the role that this concept plays in antibody identification. You'll also be able to describe how the phase of reactivity relates to antibody specificity, and you'll be able to explain the rule-in procedure for identifying antibodies. This is kind of one of the final steps that's going to help you assure that you have the right suspect. Related to both the rule-in and rule-out steps is the 95% confidence interval. We'll talk about that a little bit. Once we've covered all of that, you'll be able to evaluate anagrams for antibody identification. We're going to go through a couple of practice anagrams, and hopefully you'll also have a few other practice sheets to go through in the course itself. We're also going to cover when phenotyping is appropriate, and then we'll touch briefly, it's not displayed here, but we're going to touch briefly on when you may or may not want to use enzymes or chemical treatments in your antibody workup. So the first thing we probably want to cover is when you're actually going to be able to do this. In the immunohematology reference lab at Life South, we do it all the time. Hospital transfusion services do it some of the time. So generally, we're going to perform antibody identification when the antibody screen is positive. The antibody screen is really just kind of a reflex test for identification. Anytime it's positive, we should consider identifying the antibody. Now, if the patient has had a antibody screen a few days prior, and then the current screen looks exactly the same, it might not be necessary to perform another antibody identification panel. Practices kind of vary between facilities, but in general, you'd like to be able to rule out all clinically significant antibodies outside of what has already been identified. ABO discrepancies are another reason we might try to identify an antibody. If there are unexplained reactions in the reverse type, we should try to find out if there's an apparent specificity to them. And then finally, in some types of transfusion reactions, specifically suspected hemolytic transfusion reactions, we should use it to try to figure out the specificity of the antibody that caused it. So that was when do we do it, and this is why we actually care about specificity. Anytime you have a positive antibody screen, you're likely going to need to identify the antibody because if you're going to be giving that patient blood, you need to establish whether the antibody is clinically significant, as in whether it can cause a hemolytic transfusion reaction or if it'll have decreased cell survival. And then you need to provide blood that lacks that antigen against which the antibody is directed so that it doesn't bind to the transfused blood cells and cause that reaction. And likewise, in a pregnant patient, an antibody might be present in the antibody screen, and we need to know if that antibody has the potential to affect the baby. This is going to help predict hemolytic disease of the fetus and newborn, and maybe if an intrauterine transfusion is warranted. We would also want to give antigen-negative blood for the fetus so that the mother's antibodies don't cause a transfusion reaction. You may also need to perform antibody identification to resolve ABO discrepancies, which I mentioned on the previous slide. For example, if an A positive patient has a cold reacting antibody that's giving you a reaction with A cells, you have to know whether that's an anti-A1 or a cold autoantibody, or if it's an alloantibody that has a specificity, then you can resolve the discrepancy by using reverse typing cells that are negative for that corresponding antigen. And then, of course, I mentioned before, in the event of a hemolytic transfusion reaction, we want to identify the culprit because if the hemolysis is antibody mediated, then we can figure out the specificity and see how many of the transfused units were positive for the corresponding antigen. that might help the clinicians decide whether something like an exchange transfusion is warranted, where they would take some of the patient's blood out and then administer more blood that's negative for that antigen to try to clear out any of the red blood cells that have bound antibody but haven't actually lysed yet. But that's a topic for another lecture. So we'll get to what an antibody panel anagram actually looks like in a little bit, but it's essentially just an extended version of the antibody screen you saw in that last presentation. You have more cells with different phenotypes. One thing I want to note is that whichever enhancement technique we used in the antibody screen should be the same one that we use for our panel because we're assured reactivity. Based on the results of the initial panel, we can then consider changing enhancement, but we basically just want to fully extend that antibody screen to kind of get an idea of where our reactivities lie. The first step to any antibody workup is to label your tubes and check your patient identification, as well as the lot number that's assigned to the anagram that you're using. You want to compare that lot number to the lot number on your panel cells, the vials of donor cells that you're using, because the phenotypic expression of panel cells is not the same from one lot to another. And using the incorrect panel is almost certainly going to lead you down the wrong path. The next step is to perform an indirect antiglobulin test on all of your panel cells using patient plasma. We should include all phases of reactivity during which we saw reactivity in our antibody screen. So if we had immediate spin reactions, we would want to include immediate spin in our panel workup. Just like with the antibody screen, it's imperative to use your check cells for any negative reactions at AHG to ensure that you had adequate washing. False negative reactions are going to ruin your panel interpretation. So any of them, any of the negative reactions that the check cells didn't agglutinate, you want to repeat those panel cells against your patient plasma. So after you've performed the testing and you've recorded your results from your IAT, you want to take a step back and look at the big picture. This is a step that's hardest for newer techs, and as you get more experience, the easier this is going to come. But if you can spot a pattern immediately, it's going to help you move through the subsequent steps a lot quicker. Just like the antibody screen, your phase of reactivity is going to help you determine if the antibody is clinically significant. So if you have reactivity at immediate spin, it might not be as significant as if you had it at the AHG phase. Remember that IgM antibodies react best at immediate spin, while IgG antibodies react best at AHG. If you're seeing reactions at all phases, then it might indicate that you have multiple antibodies. And the negative reactions generally indicate that the antibody does have some sort of specificity, whereas if the entire panel is positive, the antibody, well, it might still have specificity, but it's not going to be useful to proceed through some of these other steps like the rule outs because you don't have any negative reactions to start ruling out. All right, I got a little ahead of myself on that last slide, but this is how we're going to start figuring out what antibody we have. Starting with the first negative reaction of your panel, you go through that cell's phenotype and cross off each homozygous antigen. You'll see what I mean in a moment when we go through the practice one. We only want to use homozygous cells for rule outs because these cells have the strongest expression of the antigen. And that's related to the dosage effect that I talk about on the next slide. And after we've ruled out everything we can from that first cell that didn't react with our patient plasma, we go on to the next negative cell and we repeat that process. We continue repeating it until we've ruled out every possible clinically significant antibody. And that should narrow down our potential suspects for our antibody identification. Dosage effect means that the donors who are homozygous for an allele corresponding to a blood group antigen are going to produce more of that antigen than a heterozygous donor. So looking at the top image here, we see that in that first column, we have two JKA alleles, the bars at the top. This patient is homozygous for the JKA antigen. They inherited a JKA from each parent. And for that reason, all of the KIT antigens present on the red blood cells, and, after the arrow there on the bottom portion of that image, all of those KIT antigens are JKA. And then if we look at the second column, we see that the donor has inherited a JKA allele from one parent and JKB allele from the other one. So that donor is heterozygous for both the JKA and JKB alleles. The antigens expressed on the red blood cell surface below that are mixed, right? We have the same total number of antigens, but now half of them are JKB and the other half are JKA. So that first donor we talked about has twice as many JKA antigens as the middle donor, which is heterozygous. And likewise, the donor on the right, which we haven't talked about, has twice as many JKB antigens as the donor in the middle. Because of this expression, we tend to see stronger reactivity with homozygous cells. The homozygous donors' red blood cells will agglutinate much more easily with anti-JKA than the donor with the heterozygous expression. So the reason that this is important is that if we have a negative reaction on a cell with a strong expression of the antigen, homozygous expression, we can relatively safely say that that antibody is not the antibody that the patient has in their plasma is not directed against that antigen, because otherwise we would see a reaction there. And if we were trying to rule out with heterozygous expression, we might only be observing the lack of agglutination because there aren't enough antigens present for a weakly reacting antibody to show us an observable reaction. All right, so this is an antibody panel anagram. I've animated the ruleouts on this slide, so we're going to kind of go through this together, and when I say to cross something out, you're just going to hit the space bar and it's going to cross it out. So it'll rule it out that way. It'll help you kind of check your answers. There's a few elements I want to point out first about antibody panel anagrams. Along the left-hand column, we have a number for each cell that helps us identify which cell is tested and can help in dialogue when you're discussing panels with someone else. You'll see that these cell numbers are also present on the right-hand side before our immediate spin 37 and AHG reactions are recorded. The next column under special type shows some additional phenotyping which might have been performed on certain donors. This manufacturer only prints phenotypes on the front of the panel. They won't print any genotypically derived antigens. Those are only present on the back of the panel, which you can't see right now. And then the next column is the projected RH phenotype. Sometimes that's confirmed by genotyping, but not always. And then a number, like the next column there under donor, that's in the same portion as the projected RH phenotype. That number identifies the donor of the cells used to make the reagent, and that's important because you will sometimes see repeat donors from not from one panel to the next, but usually it'll skip one. So like every 2 months you might see the same donor. All right, and so then all the way on the right-hand side of the panel we have our results. The first column is IS for immediate spin, the next one is 37C, and then the last one is for AHG. The AHG column has negative reactions marked with check marks to indicate that the check cells worked. Some facilities will add a fourth column instead just for their check cells, and then they'll record the strength of reactivity with their check cells. So you might see that on your board exams. It might be presented a little bit differently from this. So now what we're going to do is go to the first line with no positive reactions. So that first cell, we can't use that because there's a 4+ reaction at AHG. So we're going to skip cell 1. Do you see that? Cell 1, 4+ under the AHG column. means that we had a reaction there. So we don't want to use that one for our rule outs. The next cell beneath that, cell 2, that one's negative. So if we trace that cell all the way to the left, under column D, antigen D, we're going to cross that out. So go ahead and hit spacebar. So it's going to cross it out. First, where we ruled it out on that specific cell, and then along the top, so we know what's remaining at the end. Remember that the D antigen there's no antithetical antigen, so there's no potential dosage there. But the next one, we can cross out big C because that cell is homozygous for that antigen. See how there's no little c expression? So if you hit the spacebar, it'll rule out big C there. Then we can cross off little e for the same reason. It's a homozygous expression. And then CW next. We can cross that off. That's an antigen of low incidence. It has no corresponding antigen, or corresponding antithetical antigen, I mean. And then what about big K? We can't cross that off because it's negative here. We can cross off little k though. And then you can cross off KPB and JSB. What about Duffy A? Can we cross that one out? Yep, you can cross it out because it's homozygous. What about JKA? No, on this cell we can't cross it out. On cell 2 we cannot cross off JKA or JKB because they're showing heterozygous expression. But we can continue on. We'll cross off Lewis B, P1. We can cross off anti-M. We can cross off big S, and then Lutheran B, LUB, and then XGA. And that's all we can do with that cell. So we cross out a lot of them so far, but we're going to keep on going. Remember, the next step is to just go down to the next negative cell and repeat this process with whatever we haven't already ruled out. So can we use cell 3? Yes, because all of the reactions at immediate spin, 37 and AHG, those ones are all negative. Okay, so first you're going to cross off little c. Remember, it's homozygous, and then big E. We still can't cross off K or KPA or JSA or Duffy B. What about JKA? Can we cross that off now? Yep, we can cross it off because it's homozygous. We keep going. Can we cross off N? Yes. What about little s? Yep, we can cross that off too. So when you're first starting, I want you to go through each line like this to see if there's something you can rule out. And then once you get more experience, you can take a few little shortcuts. So we can't rule out anything else on 4 or on 5. What about cell 6? We can't use that one. Same with number 7, because we have reactions at AHG. What about cell 8? Look at cell 8 for a little while and tell me if you can, well, tell yourself if you can rule out any antibodies on that one. And then you can hit your spacebar to check your answer. It's JKB. You can rule out JKB on cell 8. On cell 9, look at it for a while. See if there's anything you can rule out. And then you can hit the spacebar and rule out Lewis A. It's LEA. All right, and then cell 10, can't use that one. 11, we can rule out Duffy B there. And then we're going to stop. Now, I said that when you're first starting, you want to go through every single one. But at this point, if you look at the top, we're only left with big K, KPA, JSA, and Lutheran A, LUA. Now, KPA, JSA, and Lutheran A are all considered low incidence antigens, and we are rarely ever able to rule them out. So you generally don't have to worry about those ones unless you have kind of an unexplained reaction with a cell that's positive for one of those. And I know that's kind of beyond the scope of this particular course, but you'll kind of develop a feel for that in the future. But for now, just know that Lutheran A, KPA, JSA, those are low incidence. You're probably not going to have to rule those out. So yeah, just looking at the panel for each of those ones, if you scroll down each of those columns, we only have one positive for each one, and those are all heterozygous. Now, each facility will have its own rules about how to handle those, and in our case, we can safely ignore them, like I said, unless there is an unexplained reaction on one of those positive cells. And by that, I mean a reaction that can't be explained by another antibody. So that just leaves us with anti-K, anti-big K, which is one of the most common antibodies you're ever going to come across. We've successfully ruled out all other clinically significant antibodies, and we suspect now that we have an anti-big K. So we're going to go on to the next slide here, and I'm trying to see if we need to come back to it eventually. I think that I bring up this panel again, and I don't think I have it on another slide, so you may have to come back to this slide just to look at the panel again. All right, so this is an antibody So if we were unable to rule out every single clinically significant antibody in our first panel, we would want to test more cells. And usually after a panel like that, you have a pretty good idea of which possible antibody or antibodies you could have. Remember, you can have multiple antibodies. It's not going to be restricted to just one like that example was. So we can take a bit of a shortcut and test what we call selected cells rather than running another entire panel. And to do that, we would choose a panel that's homozygous positive for one of the remaining antigens, but negative for the others. And then we would choose another cell that's homozygous positive for a different remaining antigen and negative for the others. Sometimes, no matter how much we try, there's just not a clear specificity, or maybe too much of the panel might be reactive. In these instances, it might be worthwhile to skip ahead and start phenotyping our patient to see what antibodies they could make. Because remember, a patient can only make an antibody against an antigen that they lack. So we can potentially rule out antibodies by phenotyping the patient, performing antigen typing for all clinically significant, antigens corresponding to all clinically significant antibodies. And any of them that come up positive, we can effectively rule those out as well. Okay, so the next thing we want to do is called the rule-in procedure. So there's this thing called the 95% confidence interval, and it's commonly used in research to reduce the chances of calling something which is true false. It reflects the probability that an event will occur 5% of the time by chance alone. In blood bank testing, we apply this principle to rule outs. We want to say that there is a 5% or less chance that given the same reactions, the antibody that we've identified is something else instead. Provided 3 cells positive for the antigen, so 3 cells that that reacted with the plasma are positive for the antigen in question, and 3 cells negative for the corresponding antigen showed no reactivity, we've satisfied the 95% confidence interval. Again, that's if we have 3 cells where we have reactivity with the patient plasma that express that antigen, and then 3 separate cells where there's no reactivity and the cells do not express that antigen, we've satisfied the 95% confidence interval. Now there's a few different alterations of this rule based on something called Fisher's exact method, and that uses factorial math to justify the appropriate confidence interval. But at Life South, we generally stick with 2 positive and 2 negative. On your board exams, though, generally the rule is 3. All right, and then the last step, which I mentioned earlier because it can sometimes help you when you're stuck, but this is kind of the final conclusive step to state whether the antibody you've identified is, that the patient could actually make that antibody, because they would have to lack the antigen in order to make it. So this is done by using commercial antisera of the same specificity as the antibody against the patient's red blood cells. It's a process known as phenotyping or antigen typing. It's the same thing. You perform this actually when you do a forward ABO type, because you're using commercial antisera like anti-A or anti-B against the patient's cells to identify those antigens on the patient's cells. But each individual antisera from each manufacturer and for each specificity kind of has its own instructions for use. Some of them include an incubation time. Some of them will have, you incubate them at room temperature, or some will be incubate at 37 instead. You just always make sure that you're following the package insert. In a transfusion service, it's common to perform antigen typing on the patient and then some number of units for transfusion at the same time to kind of save yourself a little bit of time, because the units, you want those to lack the antigen in order to perform your cross match. And remember, that's taking your patient plasma and your donor cells through IAT in order to provide compatible units for your patient. Now, if the patient ends up being positive for the antigen in question, and your autocontrol is negative, which an autocontrol is testing the patient's plasma against their own red cells, then I would consider your interpretation suspect. I would start to consider that maybe you didn't correctly identify the antibody, and further investigation would be warranted in that case. So here's another anagram that when I'm presenting this in person, I kind of go through it with the students. So with an online lecture like this, you can either print out this slide and try to figure it out yourself. I don't have animations for this slide, but this is another very common specificity, and you should be able to rule out just about everything except for those lows that we talked about. And yeah, hopefully you'll come up with the correct answer for that one. And make sure you check your rule of 3. We didn't do that with the anti-K because it was kind of before I even mentioned it. But with the anti-big K one, we did have 3 positives, 3 positive reactions where the anti-K was expressed, and at least 3 negatives where it didn't. So make sure you do the same thing with this one. And then this slide is intended to be practice for selecting cells in case you weren't able to resolve or fully identify your antibody in the first panel. If you were unable to, I think in this instance, what is it, rule out? Yeah, oh yeah, you couldn't rule out JKA with your initial panel. So now you're looking at some cells that you might want to use. Would we want to use cell 1? I forgot to mention that it looks like this patient has an anti-K, right? Yeah, suspected anti-K. So if they have a suspected anti-K and we want to rule out JKA, we wouldn't want to use the first cell for 2 reasons. The first is that JKA is heterozygous, so of course we don't want to use that for rule outs, but also that cell is expressing the big K antigen. And so our suspected antibody would probably react there, and then we wouldn't have a negative cell to use. And then cell 2, same thing. We don't want to use, well, not exactly the same, but we don't want to use a heterozygous expression of JKA there. But cell 3, we have a homozygous expression, and that cell is negative for big K. So we would want to choose that cell. And so we would just test that cell. Now, if there were other antibody specificities that we wanted to rule out, we would include those as well, making sure that they're negative for big K and negative for JKA, but homozygous positive for whatever else we're trying to rule out. So in an ideal situation, a single antibody would react at the same strength throughout the entire panel, like that anti-K did. It was all 4+. It was either 4+ or negative. But there's a few reasons why you might see some mixed reactivity. And I don't want you to get this concept confused with mixed field reactions. Remember, I mentioned that during the gel slide in the previous lecture. It's not the same thing. When you're testing against panel cells, these are a homogeneous population of red blood cells. You shouldn't see mixed field reactions. So we've gone over the dosage effect. That's one thing that can cause mixed reactivity. Certain blood groups exhibit dosage, or homozygous inheritance will lead to a stronger expression of an antigen, and that translates into a greater strength of reactivity with antibodies. But antigenic expression can vary in other ways too. P1 antigens, for example, show varying degrees of expression for no particular reason. The I antigens, but big I, little I, can vary depending on age or disease state, because those are carbohydrate branching chains, and so sometimes some conditions will cause you not to develop those chains as fully. And then even the D antigen can show varied expression. I mentioned that there's no antithetical allele, but there is sometimes genetic mutation, such as weak or partial D patients, but then also the other Rh antigens can affect the expression of the D antigen. Um, Mixed field reactivity is also a hallmark of the development of multiple alloantibodies. So if dosage doesn't explain the varied pattern of reactivity, you should definitely consider that there is another alloantibody present, and perhaps run even another full panel, just to see if that varied expression kind of settles out. If you end up detecting some reactivity on cells that are lacking the antigen or the corresponding antigen to the antibody you think you've identified. Pan-reactivity occurs when you have no negative reactions at all. This could be due to a certain drug-induced antibody or an autoantibody, an antibody against the patient's own cells. Those are usually of broad enough specificity that they'll just react with any cells. Or antibodies against high incidence antigens. If you remember looking at some of those panels, we had some of those donors are positive, or all of those donors would be positive for some of those antigens, such as Lutheran B or little k is usually expressed on all those cells. So high incidence antigens are expressed in greater than 99% of the population. And then also you can have pan-reactivity if the patient has so many different alloantibodies that only phenosimilar cells, or cells that have the exact same phenotype as the patient, would end up being negative. So if they just have multiple antibodies, they've made basically everything that they can, and your panel just happens to line up so that none of those donors are phenosimilar, well, then you would have reactions throughout the entire panel. In the immunohematology reference lab, these are our #1 most common workups, because hospitals just don't have the resources to deal with them, so they end up sending them to their reference lab. They're kind of a pain in the transfusion setting, because they kind of tend to lack experienced personnel necessary to address all of these possibilities that I've given you. So the first most important step when you're dealing with pan-reactivity is to obtain an accurate patient history. Sometimes a drug history is all you'll need to resolve it. Pay close attention to the results of your DAT and your autocontrol. If the autocontrol is negative, it's unlikely that you've got an autoantibody. We can occasionally remove some of the reactivity with proteolytic enzymes, which we'll go over in another lecture, or chemical treatment of the red cells. There's dithiathreatol, or DTT as it's also called, and that's commonly used to destroy the KEL system antigens and a few others. So if you have an anti-little k, you could destroy that little k on your testing cells and see if there's any other alloantibodies underneath of it. And then proteolytic enzymes are also commonly used. These kind of destroy certain blood groups like Duffy and MNS while enhancing others. Enzyme treated panels can be performed in parallel with your other panel that you ran. But those will be discussed in more detail in a separate lecture. Yeah, objectives are next. We're done. All right, so now we're going to go back over the learning objectives. Remember that these work best if you pause the audio and then see how many of them you can kind of figure out and think through. And then after we go over them, anything that you might have missed, it might be worthwhile to go back to those slides and kind of recap. So first, just explain the rule out method. How does that work? This is where you use your negative reactions to cross off homozygous antigens to help you kind of narrow down which antibody or antibodies may be present in your panel or in your patient plasma. Describe the concept of dosage. It's an important one. It's going to show up on your board exams for sure. Dosage is the effect that inheriting two of the same alleles, so homozygous inheritance, corresponding to an antigenic expression, leads to a stronger expression of that antigen. And meanwhile, heterozygous inheritance would lead to a weaker expression of each antithetical antigen in that blood group system. Don't forget that we want to rule out antibodies using homozygous cells, because otherwise we might unintentionally rule out a weakly reacting antibody. How does phase of reactivity relate to the specificity of an antibody? Antibodies of certain blood groups and certain molecular configurations react best at certain phases. So, for example, IgM antibodies like anti-M or anti-N react best at room temperature or at immediate spin phase, while IgG antibodies, such as the Duppies and the Kids and the Kells, tend to react best at AHG phase. Remember that most of them can't even cause a lattice formation without AHG anyway. Let's see, can you explain the rule-in procedure? It's where we want 3 positive reactions with cells that express the corresponding antigen and 3 negative reactions with cells that do not express that antigen in order to achieve our 95% confidence interval. And what was that? The 95% confidence interval is the statistical significance of reporting the correct antibody with only a 1 in 20 or 5% chance or less that the reactivity we obtained would be seen by random chance. Make sure you can evaluate anagrams. Hopefully this program is going to give you plenty of practice with that. And you'll get more training with it in your clinical rotations. And when is phenotyping appropriate? Well, at the end of your workup, once you've identified your antibody with 95% confidence, we want to phenotype the patient for the corresponding antigen to ensure that our patient can actually produce that antibody. There may be times when phenotyping can narrow down a suspected antibody too, such as when we have a pan-reactive antibody. And that's it for this lecture. Good luck with your quiz, and please reach out to us if you have any questions.